Dr. Devanathan MBBS, MD Pulmona, Rye Medicine, Qualification College, University, MBBS IRT Paranjurai Medical College, Tamil Nadu, MD Pulmona, Rye Medicine, Stanley Medical College and Hospital, Chennai and Government Hospital of Thoracic Medicine, Tambaram, Experience, Assistant Professor, Stanley Medical College and GHTM Tambaram June 2020 to till date, assessing previous medical records, identifying and treating pulmonary comorbidities and complications in patients being evaluated or treated for various malignancies, being part of a team of experts and holding joint discussions and clinical sessions, working in COVID wards and performing duties in COVID isolation wards. COVID, clinically assessed and treated a wide range of patients on an outpatient basis. Consultant pulmonologist, Venkataeswara Hospital Nandhanam. Asthma Studio Velashiri. Skills, management of varied respiratory diseases on an outpatient basis with extensive experience in TB, airway diseases, ILD and lung malignancies. Have worked in GHTM Tambaram, with experience in treating MDR and XDR TB patients with bedaquiline and delamanid drugs. Identify, evaluating and treating various respiratory emergencies like exacerbations of COPD divided by asthma, ILD, ARDS, drowning and inhalational injuries. Well-versed in performing diagnostic bronchoscopy including procedures like endobronchial and transbronchial biopsies and needle aspirations. Well-versed in doing thoracic ultrasound and thoracoscopy. Various presentations done in state, NATIO and AL conferences. Associations. Member of 1. Indian Chest Society. 2. Indian Medical Association. 3. European Respiratory Society. Dr.
Good evening to everyone present here. Warm welcome to everyone present here. At the outset, I thank the organizers for giving me this opportunity. My topic for today will be to discuss upon the latest guidelines in the management of tuberculosis. Evolution of TB programs in India. We have moved from National Tuberculosis Program from the RNDCP to National Tuberculosis Elimination Program. It's the current program for guidance for management of TB patients. It has been implemented from January 2020. So, how much is the global TB burden? In India, we get roughly around 27 lakhs people getting TB infection, and the mortality is between 4.5 lakhs of the mortality for in TB patients per year in India. So, the NTB strategy by the WHO is to end TB elimination by 2030, while India's target is to eliminate it by 2025. So, how is the infection getting spread? It's caused by tuberculosis infection is caused by mycobacterium tuberculosis. It is the patient acquires the infection due to the inhalation of aerosol droplets. When you inhale aerosol tuberculosis basically, one of the four outcomes can be possible. One, there is immediate clearance of the organism from our body. It gets completely eradicated from our body. The second is a primary infection. It occurs immediately. You happen as soon as you inhale the patient, immediately in a few days, the infection becomes into a disease in a few subset of people. That's closely anywhere between 5 to 10%. In the large majority of the 90% of the patients who inhale the vessel, there's a latent infection, which means later during many years due to the immunosuppression gets deactivated. So either the organism is completely eradicated from the body, or there is a primary disease, or it will become only as an infection and not as a disease in a subset of people, 90% of the people, or there might be a later reactivation some years later due to immunosuppression. So who are the high risk individuals who are more prone to get from the infection more to the disease? So those with HIV infection, those with chronic renal failure, those who have poorly controlled diabetes mellitus, those who have severe immunosuppression, such as those around transplant patients who are on immunosuppressants, and autoimmune patients on steroids and other immunosuppressants. Then in children and pediatric population. These subset of population we have to be more careful and evaluate. There is a higher chance of them getting from the infection to getting passed into as a disease. So, what are the common symptoms that the patient presents? There will be a chronic cough that is persistent for more than 2 weeks. There will be a fever with a classical evening rise in temperature that will also last for more than 2 weeks. There is a significant weight loss and loss of appetite and hemoptysis. These are the 4 cardinal symptoms. So while diagnosing a patient, we take into account 3 criteria. One is the clinical criteria. This 4, if any of the 4 today's talk is pertaining only to pulmonary TB. So for clinical, based on clinical history, these are the 4 points that has to be taken into account. Cough, chronic cough, fever with an evening rise of temperature, with a significant weight loss or loss of appetite, and hemoptysis. This is clinical criteria. For drug resistant cases, whom do you suspect drug resistance? So if you're treating a patient and he's not getting healed up, so one of the causes can be due to a drug resistant, he might be a drug resistant patient. Then the other categories include those who are in contact with a drug resistant TB. He shows up symptoms of cough or fever, then you suspect drug resistance in these subset of patients. Pediatric TB cases are not responding to your routine treatment. HIV, TB, HIV co-infection have a higher incidence of drug resistant, turning up into a drug resistant TB case. And those who are found for already previously treated for TB and then now they are again turning up to be for positive. Relapse cases, they have a higher incidence of, you should keep a suspect of drug resistance in these cases. So cases, while writing the case or in a diagnosis, there are 2 types. One is a clinically diagnosed case. Clinically diagnosed pulmonary tuberculosis. Once those who are diagnosed only based on clinical history or radiological features, you write this as clinically diagnosed TB. For whom there is a microbiological confirmation, either based on your sputum or your gene expert or your culture. If any one of these methods is there, then you have to label them as a microbiologically confirmed TB. You are justified in starting a patient on ATT based on clinical, but the terminology should be correctly mentioned in the patient. Whether it's a clinically diagnosed, even all your node or anything, you take an FNAC or a culture, if it shows a necrotizing granulomatous lymphadenitis or inflammation, those will come under the category of clinically diagnosed tuberculosis. Those only with either on sputum or culture, if they are positive, then you term them as a microbiologically confirmed TB. A clinically diagnosed, as said, is on those who are diagnosed based on those clinical criteria or radiological features or histopathology, then we term them as clinically diagnosed TB. So classification, first you classify either whether it's a pulmonary TB or an extrapulmonary TB. Among the pulmonary TB, you classify them first as a drug sensitive or drug resistant, then clinically diagnosed or microbiologically confirmed. So for chest radiograph, you go, what are the commonly seen in a chest radiograph of a TB patient? You will probably find the lesion to be in the upper lobes because there is high oxygen tension and poor lymphatic supply. The infiltrates, the radiograph pattern can either show infiltrates, can either show a cavity or a consolidation or a miliary pattern. Any of these patterns can be seen, but predominant involvement will be in the upper part of the X-ray. The lower zone of the X-ray, there are certain diseases, the lower zone of the lungs can get involved. The many immunosuppressed states such as diabetes, HIV, in those patients, the lower zones of the X-rays will also show up. They classify any form of infiltrates or cavity can be present even in the lower zone. CT is more sensitive than a brain X-ray for identifying early and subtle parenchymal and nodal lesions. For sputum, now we have gone after X-ray, now we have gone to sputum examination. Sputum may be obtained spontaneously by coughing. We should always instruct a patient that they should give sputum for the test and not saliva. If they give saliva for the test, it can turn out to be false negative. We obtain one sputum sample at the time of examination and next we ask them to come on the next day early morning sample. So 2 sputum samples we are getting. For those who are not able to produce sputum, we can index sputum by giving chest physiotherapy or saline embolization. For still if the patient is not able to produce sputum, the other alternative methods are you can ask for a overnight fasting gastric juice. We ask the patient to be early morning, we put a rice tube, we inject some 10 ml of normal saline, then we re-aspirate it and we send for a sample. The best method would be bronchoscopy is a better alternative. The yield and sensitivity is better with bronchoscopy. So these are the diagnostic methods. First we will look into sputum. So sputum, either this is a microscopic evaluation stage. So among the microscopic evaluation, there are 2 types. One is your normal staining where the lesions. The organism appears as this pinkish color rods. Another is a fluorescent microscope. In this, if the organism is tuberculous bacilli is there, it will in a black background will show up as bright green spots. So these are the 2 direct sputum microscopic evaluation. We are actually seeing the organism with the microscope after staining. So next comes PCR based techniques such as your CBNAT and line probe assay. These are based on PCR based tests. Here you see, so what we do is for PCR based test, you need to collect the sample in a falcon tube, not in a routine container. For all your cultures and for CVNAT and line probe assay, you should collect the sample only in a falcon tube to avoid contamination. So what they do is after collecting the sample in the falcon tube, they will mix an reagent to it and they will shake it in a container. Then they will put 2 ml of this in the box with a target with a barcode sign in this. Then with the barcode sign, it will with the container with the barcode, they will keep it inside a machine. After 2 hours, we will get to know the report. After 2 hours, we read the barcode, and in the computer we can see the report whether there will be 2 parts of the test. First part is whether MTB is detected or not, mycobacterium tuberculosis is detected or not. If it's not detected, well and good. If it's detected, we have to look for the second part of the test, whether rifampicin resistance is present or not. The turnaround time is 2 hours. We can get the report within 2 hours. So we can get to know whether your mycobacterium tuberculosis is present or not, and in the second part whether rifampicin status, whether the sputum sample or the person is resistant to rifampicin or sensitive to rifampicin can be ascertained within 2 hours in this test. The other part, similar to gene expert, we have another test called as line probe assay. This is also based on the PCR based test. The advantage with line probe assay is, in addition to rifampicin, this is also technique is the same, but the turnaround time will be close to 3 days. In this, we will be able to identify whether, even in addition to rifampicin, whether isoniazid acid is sensitive or not. So among the 4 drugs that we give, isoniazid acid, rifampicin, pyrethrolamine and ethambutol for drug sensitive TB, 2 of the drugs we can get to know whether it's sensitive or resistant in the patient within 3 days. So the main advantage with LPI is we will be able to get know both isoniazid acid in addition to rifampicin as ascertained by CVNAT. So these are our drug resistance testing. So CVNAT and line probe assay. The method is the same for both. The third comes culture based test. So we have 2 cultures, either a solid culture or liquid culture. This is a gold standard test with the highest sensitivity and specificity. So but the main problem is the result takes anywhere between 2 to 3 months to come. We can ascertain all the first line and second line drugs whether they are sensitive or resistant. That is the main advantage and is the most sensitive test. This is a solid culture where they grow the organism in the culture. If it's positive, you can see the growth in like this rough and rough colonies. Here, this is the solid culture. In liquid culture, it is known as HJ culture. In liquid, it is known as midget culture. Mycobacterium growth indicator tube. If there is fluorescence there, it indicates the growth of mycobacterium. Main advantage, as said, is highest sensitivity, and we can ascertain for sensitivity whether the drugs for all the first line drugs and second line drugs sensitivity pattern can be known through only your culture methods. Now, in addition to all these methods as explained, there is another newer technique, that is whole genome sequencing. Here, with the sputum sample, we will be able to, so as CVNAT it takes 2 hours, LPA it takes 3 days. Your solid culture and liquid culture can take anywhere between 3 months for the report and for to know the resistance and sensitivity pattern for all the drugs. But in whole genome sequencing, we can know the sensitivity and resistance pattern for all the drugs within a matter of 2 weeks. But the problem is that it's still not standardized yet. It's still not approved. It's in the stage of approval. So as of now, approved tests include your sputum microscopy, your CVNAT and LPA based test. These are based on PCR and your gold standard culture based test. So now you have diagnosed the patient as tuberculosis, either based on your sputum reports or CVNAT or culture. So now how you are going to, now before starting treatment, what you should know? You should see the patient for CBC to check mainly for platelet levels you have to check, because rifampicin can cause thrombocytopenia. So CBC is done before starting the patient on treatment. LFT, RFT is done before starting the treatment, because we need to know whether there is a pre-existing liver disease or a renal disease, or whether after starting treatment, if the levels are deranged, it's mostly due to after starting the treatment. There is bidirectional screening in the program. All patients of tuberculosis diagnosed should be tested for HIV and for diabetes also now, because both the diseases are associated with more severe disease in tuberculosis. So all the TB patients will be checked for HIV and vice versa. HIV patients will be checked for TB. And fasting postprandial and HbA1c should also be checked before starting a patient. Chest X-ray and ultrasound abdomen to rule out any dissemination in pulmonary TB, and also you clinically check for any nodes, whether it's only located in the pulmonary TB or if it's a dissemination, because the treatment duration will change based on that. So what are the guidelines? So before what we are treating for intensive phase, we are giving for 2 months we are giving 4 drugs. This was the previous regimen. Isoniazid acid, rifampicin, pyrazinamide and ethambutol. We were giving for 2 months. That is still the same. But what has changed now for the past 2 years is in the continuation phase for the 4 months, we are in addition to isoniazid acid, rifampicin, we have added ethambutol in the continuation phase. Why we have added this? Because there is a high incidence of isoniazid acid resistance in India. WHO recommends this regimen only, but in countries where there is a high incidence of isoniazid acid resistance, they are recommending to add ethambutol also in the continuation phase. Because if the person is isoniazid acid resistant and we are not assessed it properly, then the patient will be getting only rifampicin, a single drug in the continuation phase for 4 months. So in order to prevent that, we are giving ethambutol in the continuation phase. This is specific to India. This regimen is specific to India. It may differ from country to country. Okay. So how the drugs are? So this is the drug we give in the intensive phase. For the first 2 months, it will be in red color. In the continuation phase, it will be in green color. So each of the tablets will contain all the 4 drugs. So fixed dose combination. That's what FDC stands for. So each of the tablets will contain 75 mg of isoniazid acid, 150 mg of rifampicin, 400 mg of pyrazinamide, and 275 mg of ethambutol. So each tablet has 4 drugs. So 4 is a fixed dose combination. So while writing the treatment chart, you should write as 4 FDC for the intensive phase. And there are 5 weight bands. If someone is between 25 to 34 kg, we give them 4 FDC, 2 tablets. And anywhere between 35 to 49, they will be receiving 3. Suppose if the patient is 55 kg, they will be getting 4 tablets in this weight band. And anywhere between 65 to 75, they will be getting 5 tablets. And those above 75, they will be getting 6 tablets. So 4 tablets, so we are writing as 4 FDC and 3 OD. So they have to take 3 tablets daily now. So 3 OD, that's how we write the application. So once they complete the 2 months, then comes a continuation phase. So continuation phase, we are going to give 3 tablets, so 3 FDC. As shown before, this will be your intensive phase 2. It will be in red in color. So if someone is say 50 kg, we have to give 4 tablets in this. They have to take the tablets within an interval of 15 months. Not 1 tablet in the morning, no, 1 in the afternoon, not 1 in the night, not like that. We have to take the tablets within a period of 15 minutes so that to achieve bioavailability for the drugs. So so someone is say is above 75 kg, they should take 6 tablets in this daily at 24 hours interval. So what are the differences between previous and like for the past 3 years, why we changed from the intermittent regimen to the daily regimen? What we found was previously we were giving ADT on alternate days. What we found was those who even if the patients are taking the regimens daily, there was a high relapse rate. People were getting the tuberculosis again. So in order to avoid that, they have now shifted from intermittent regimen to daily regimen. Now ethambutol we are adding in the continuation phase. So throughout the 6 months, patients getting ethambutol. The main side effect with ethambutol is it can interfere with the visual acuity. It can cause color blindness, it can cause diplopia. So every month when a patient comes to you for follow-up, we should definitely ask for any visual change is present or not. Because this has been a new addition. If any difference is there, immediate ophthalmic evaluation is based. Now the patient should be followed for 2 years. This is also in the new recent training. So from intermittent, we have shifted to daily regimen. Ethambutol is now being added in the continuation phase. We are giving fixed dose combinations. And the follow-up is now based up to 2 years. So we have set for now the routine patient we are treating for 6 months. Certain class of patients will require longer duration of tuberculosis patient. Those include CNS TB, skeletal spinal TB, and disseminated TB or biliary TB will require anywhere between 9 to 12 months of treatment. So what are the common adverse effects? We have started a treatment. So what are the common adverse effects we see? One main thing is the color of the urine will turn red. That is because of rifampicin. It is normal and it is normal. We need to reassure the patient that this is normal and nothing to get worried about. Next is GI upset is very common. That can be caused by any of the oral medication. It can be circumvented by giving them on antacid and proton pump inhibitors. Then there can be burning sensation in the feet caused by isoniazid acid due to peripheral neuropathy. Can be circumvented by addition of pyridoxine. Abdominal pain and nausea are commonly related to rifampicin. We should reassure the patient. If the patient is still intolerable, we can then transfer to stop the drug and re-administer the different drug. These are the most common side effects predominantly seen. One advice is those who are for female patients, if they are on oral contraceptive pills, rifampicin reduces the effectiveness of the oral contraceptive pills. That should also be kept in mind. So higher dose should be recommended. So tuberculosis in pregnancy, for normal drug sensitive patients, no need of any dose modification or anything. You can start on the routine regimen as prescribed for normal patients. Even during pregnancy and lactation, there is no interference. If a patient has a pre-existing renal disease, we check for in which category they are. If they are in normally isoniazid acid and rifampicin, they are eliminated by biliary excretion, so no change in dosing is needed. If for dosing is a change in dose is needed mainly for ethambutol and pyrazinamide. It's indicated in CKD patient stage and 4 and 5 when the creatinine clearance is less than 30. What we do is we give pyrazinamide and ethambutol on alternate days. Isoniazid and rifampicin we give the regular dose. Ethambutol and pyrazinamide we give them on alternate days. Alternatively, what can be done is ethambutol can be replaced by fluoroquinolone, in which moxifloxacin is preferred. So isoniazid, rifampicin we give moxifloxacin and alternate day pyrazinamide. Any one of the two regimens can be given. For those patients with any LFT derangement or liver disease, we normally check for the SGOT and SGPT levels. If they are more than 3 times normal, say above 120, we need to modify ATT. There are two common regimens. We usually get a medical gastroenterologist opinion also when we are changing the ATT. So, most common regimen is either one of the two will be most commonly preferred. There are other regimens also. So, one regimen is we give 2 months of isoniazid, ethambutol, and streptomycin. After the 2 months, we stop the injection. We continue isoniazid and ethambutol for 10 months. So, the total duration is anywhere between 1 year. For the first 2 months, we give streptomycin, isoniazid, and ethambutol. For the next 10 months, we give isoniazid and ethambutol. The other regimen is we can give 2 months of streptomycin, ethambutol, and levofloxacin. Again, after 2 months, we stop the injectables and we continue with 10 months of ethambutol and levofloxacin. This is for those patients with liver disease. So, individual drug dosages for isoniazid, the doses for adults is 5 mg per kg. For rifampicin, the individual drug dosage is 10 mg per kg. For pyrazinamide, it's 25 mg per kg. And for ethambutol, it's 15 mg per kg. So, moving on from drug sensitive TB is the main part that most of us are going to handle. So, for drug resistant TB, I'll just give a slight outline that what are the types of drug resistance that is being now documented and what are the treatment options that we are giving. So, for drug resistant TB, we have 4 classes of the types. One is an isoniazid monoresistant. This is only the patient is resistant only to isoniazid. The other part is MDR TB. For MDR TB, they are resistant to both isoniazid and rifampicin. The term pre-XDR TB we labeled it when the patient is resistant to isoniazid, rifampicin, in addition to any fluoroquinolone such as levofloxacin or moxifloxacin. That term is pre-XDR. For XDR TB, for XDR TB, in addition to fluoroquinolone, they should be either resistant to either bedaquiline or linezolid, any of the one group A product. So, for isoniazid monoresistant, the patient is resistant only to isoniazid. It can be assessed via line drop assay. Line drop assay, as I said, will tell whether NTP is detected or not and whether the patient is sensitive or resistant to isoniazid and rifampicin. In isoniazid monoresistant, the patient will be sensitive to rifampicin but will be resistant to isoniazid. The regimen is simple. We give 6 months of rifampicin, pyrazinamide, and ethambutol, but only instead of isoniazid, we change it to levofloxacin. Only one drug gets changed. No intensive phase, no continuation phase. The only one phase for 6 months, the same regimen is given. Isoniazid is resistant, simple, we replace it with levofloxacin. Rest of the other 3 drugs we continue. So this is for the isoniazid monoresistant part. For MDR TB, the patient should be resistant to both isoniazid and rifampicin. So pre-XDR, for a patient to be termed as pre-XDR, in addition to resistance to MDR, isoniazid and rifampicin is resistant to any of one of the fluoroquinolones such as levofloxacin or moxifloxacin. For XDR TB, in addition to pre-XDR, he should be resistant to at least any one group A drug, either bedaquiline or linezolid. So these are the group A drugs. How we form the regimen for MDR patient is we need to give 5 drugs in the intensive phase and 4 drugs in the continuation phase. So we take for 5 drugs, there are 3 drugs in group A. and there will be 2 drugs in group B. So levofloxacin, bedaquiline, linezolid. We take 3 drugs in group A. We take 2 drugs that are present in group B. So 5 drugs. 3 plus 2. 5 drugs we found the regimen. If you are not able to give any one of the drugs due to resistance or intolerance or patients have any contraindication to any of the drugs, we substitute you with any one of the group C drugs. So 5 drugs we need to give for the intensive phase. That's how the regimen is formed. We take 3 drugs in the group A and we take clofazimine and cycloserine in group B. In group A we take levofloxacin, bedaquiline and linezolid. If any one among the drugs we are not able to give in these 5 drugs, we change it, we substitute with group C drug. So the regimen for isoniazid monorestant is 6 months. We have 2 regimens based on it. A shorter bedaquiline regimen that is for 10 months and all oral MDR regimen that is for 20 months. So for pre-treatment evaluation, this is same for drug sensitivity. In addition, we ask for a cardiologist opinion since we are giving bedaquiline and delaminate and after opinion for ethambutol if the patient is going to be started on either ethambutol or linezolid, and psychiatric opinion for cycloserine and isoniazid. These are the additional opinions we get. So this is a new regimen. This been started. This is what we are giving for the past 2 months. So this started from April 2022. This is a shorter bedaquiline regimen. If a patient is newly diagnosed on MDR regimen, we give them for this regimen. It's for 10 months duration. Intensive phase is anywhere between 5 months roughly, and continuation phase is for 5 months. We give these 7 drugs for 5 months, and this in the after 5 months we give another 4 drugs in the continuation phase for 5 months. These are the 7 drugs: bedaquiline, levofloxacin, ethionamide, clofazimine, high dose of isoniazid, pyrazinamide, and ethambutol. For continuation phase, we give levofloxacin, clofazimine, pyrazinamide, and ethambutol. So 10 months the regimen gets over. Due to any contraindication, if you are not able to give the shorter MDR regimen, such as a patient is having pregnant patients, for extra pulmonary PLHIV patients, disseminated disease, intolerance or resistance to any of the 7 drugs that I mentioned before, patient will be started on a 20 months regimen. So for 20 months regimen, there will be intensive phase consists of 5 drugs: bedaquiline, levofloxacin, linezolid, clofazimine, and cycloserine. This will be given for intensive phase is for 6 months over here, and the continuation phase will be anywhere between 14 months. Only bedaquiline gets stopped after 6 months. The rest of the 4 drugs will be given for 14 months. As I mentioned, these 3 are the group A drugs: bedaquiline, levofloxacin, linezolid, clofazimine, and cycloserine. Anyone having any contraindication to a short MDR drug, short MDR 10 months regimen will be started on all over 20 months regimen. If there is resistance to any one of these drugs, the patient's regimen will be substituted with a group C drug tailored according to that individual's resistance pattern. So these are the 2 new drugs that will be available. So from the whatever drugs, first line drugs I mentioned have been discovered in 1960. After 1960, only 2 drugs have been newly diagnosed for tuberculosis, have been approved for tuberculosis. One is bedaquiline and the other is delaminate. Both the drugs are under the conditional access program. It's only available in selected institutes where they are giving for trained centers for drug resistance that are dealing with drug resistant TB cases. So for all patients of there are certain set of patients you need to do CBNAT upfront. So instead of doing sputum AFB, the main advantage with CBNAT, that molecular based test, is even with the low bacillary load, we'll be able to detect the organism. So say for like even with 100 or only if 100 bacilli is there, CBNAT will be able to detect the disease. So whom is PLHIV patients, extrapulmonary, there will be positive bacilli, only a few bacilli will be there. In these patients, it's better you start doing CBNAT upfront rather than going for a sputum smear AFB. Instead of microscopy, better to go for CBNAT in HIV patients, in EP, extrapulmonary TB patients, in smear negative, but the X-rays or X-ray or CT is suggestive of tuberculosis patients, and those with contact of drug resistant TB patients. So I explain the main indication of this flow chart is in all smear positive patients, you should do an upfront CBNAT. This is also a new guidance. So any patient with smear positivity, you do CBNAT now. Whether at least we'll know whether among the 4 drugs, whether rifampicin is resistant or sensitive. So basically, for drug sensitive patients, to summarize everything, for a drug resistant TB patient, you are going to give them 4 drugs for 2 months in the intensive phase, and for the next 4 months, you are going to give 3 drugs. For INH monoresistant TB regimen, it's going to be 6 months of 4 drugs continuously. For shorter MDR regimen, it's going to be consist of 10 months. You give 7 drugs in the intensive phase and 4 drugs in the continuation phase. For all oral regimen, it's going to be 20 months. For intensive phase, it's going to be for 6 months, you give 5 drugs. And for the continuation phase, you are going to give these 4 drugs. These are the main category of drugs that you are taking now for tuberculosis patient. Now you have given the treatment for the prescribed amount of time. How you should assess whether the patient has improved from completely recovered from tuberculosis. As said before, there should be a clinical improvement. There should be a complete resolution of symptoms such as cough, fever, loss of weight and appetite should be there. Should be completely gone, and there should be a significant weight gain. Each time when the patient comes to you for follow-up during treatment also, it's imperative that you ascertain whether the patient is clinically improving and the weight should be documented each time. Microbial sputum should be converted from sputum smear positive to smear negative conversion should be there. During follow-up, it's better that you take sputum smear AFP out. At the end of treatment, don't take CBNAT because it may show up fast dead based also. So only during starting of treatment, it's better to go for your PCR-based techniques such as CBNAT and AFP. End of treatment, go for only AFP. That will show whether the organism is there or not. Then the third part is the radiological lesion, as mentioned before, should completely be resolved. Then only we can say the patient has completed treatment and is cured of the disease. So for now, the government has made tuberculosis a notifiable disease. For each patient, there is an IMA ID will be generated. So while they are giving sputum sample itself, the ID will be generated. So based on the ID, all the reports will be entered on the ID. For government institutions, it will be automatically reported. For private, we have REACH, where they will do the niche identification and all the data, whether the patient is taking the tablets, whether they are coming for follow-up, whether they have completed treatment or not, what is the status of what all sputum samples they have given, whether AFP or CBNAT alone they have given, or whether they have given for drug resistance patient or not, even first-line LPA, all your cultures will be documented based on one ID. So this should be done. All cases should be notified. In governments where they do it in the government itself. For private, you should notify REACH because it's a notified disease. If not, it's an absence action. Incentives are given to patients for their economic well-being also. 500 rupees per month will be deposited to the patient's bank account. If once IMA is notified and their tuberculosis is confirmed, each month 500 is being given to the patients for the economic well-being. COVID and TB. Last 2 years, due to the COVID pandemic, there is a drastic reduction in the reporting of TB. A lot of resources that was previously earmarked for TB, elimination of TB has been diverted for COVID. Hence, the notification has been drastically reduced and the funds are also been largely diverted. What we are seeing as such is there are TB deaths have been increasing for the first time since 2020. For a long duration of time, the record was the TB deaths were reducing. Now what we are seeing is there is an increase in the number of TB deaths. One more point is there is an increased COVID will change the pattern because a large population of people have now been exposed to steroids and immunosuppressants for the treatment of COVID. We have been given tocilizumab, we have been given prednisone and all the steroids. So that factor should also be done. So there might be a difference in the presentation of tuberculosis. We are seeing different types of tuberculosis. We are seeing more types of disseminated tuberculosis. Even rare types of TB we are now seeing. The other effects will be able to appreciate only when the pandemic ends. But as of now, what we are seeing is there is the increase incidence of dissemination TB we are seeing, and rare amounts of TB, rare types of TB also we are seeing post-COVID. So, short film.
Last slide.
Video. They are. So the theme for this year TB program is to invest to end TB. So we need to invest so in order to save the lives that are lost due to TB. This is a disease that has been there for centuries. It's a bacterial disease. We have drugs for it, but still we are losing patients. The TB deaths in India is anywhere between 4.5 lakhs, roughly around 4.5 lakhs people we are losing due to TB. There are 1,200 deaths occurring every day, and every 2 deaths are being due to tuberculosis every 3 minutes. Ways to reduce TB mortality. The main thing associated with TB is the stigma. Patients don't want to tell the rest of the people around they have a TB disease. Even if a patient is somewhere in, let's say in Nandanam, he's asking whether he can get tablets from side effect, because he doesn't want his close persons or anywhere friends or relatives to know that he's been affected with TB. The large subset of persons, they don't reveal that they are having tuberculosis. Ways to reduce this, early diagnosis is very imperative. Those who are having chronic cough, a simple X-ray or sputum examination will be able to easily know whether the patient is having TB or not. Counseling regarding the psychosocial aspects, whether it's a curable disease, treatment needs to be taken for a long duration. A lot of people stop treatment in between due to poor adherence, due to alcohol, or once they get better, they stop the treatment. Proper counseling is needed in order to circumvent the loss associated with economic pay. They should be counseled because they have to take the treatment for 6 months. They have to come regularly for follow-up. So proper social counseling should be done, and they should also be told the nature of the disease, and the family members should also be explained regarding the disease. Third point is we are losing a large number of patients due to hemoplasia. There's a cavity, people present late, it turns into a cavity, and there's a large there can be an incidence of hemoplasia and going for aspiration pneumonia. So that is one of the main reasons we are losing a large number. Even on treatment, we lose a large number of treatment patients due to hemoplasia, which can be circumvented by early bronchial artery embolization, advising them for early bronchial artery embolization in these patients. For drug-resistant TB, for drug-sensitive TB, the diagnostic methods that we have and the tablets that we have is more than adequate. But for drug-resistant TB, we need newer, faster, and sensitive diagnostic methods. Because only by culture we will be able to know whether all the drugs is sensitive or not. That will take anywhere close to 3 months. Newer drugs are the need of the hour because the survival rate is still poor in drug-resistant TB patients. Both in MDR and XDR, the survival rate is very poor. Surgical interventions, whether if only one lung is involved or only a part of the lung is involved, they can either go for a lobectomy or segmentectomy or a pneumonectomy for one lung alone. And newer potent adult vaccines, similar to pneumococcal influenza vaccine, whether a newer vaccine more potent than what we have already BCG would be more better to reduce the incidence, on which in turn will be also able to reduce the number of deaths due to TB. So these are the new drugs in the pipeline. Only 2 have completed the phase 3 and they have been approved. Vidafinil, Dilaminid and Pretamid. There are a few other drugs that are still under phase trials. Only 3 drugs have been approved as such. There are various trials. These are all trials for drug-resistant cases. Now the duration is anywhere between 20 months. For all other regimens, 20 months. And for shorter regimens, anywhere between 10 months. All the regimens are assessing whether they can reduce the duration from anywhere between 6 months. These are the vaccines under trial. Adult vaccines under trial, whether they are being able to reduce the incidence of TB among the infected patients. Take home message. So, what is the changes that has been done from previous to now is instead of the daily intermittent regimen, we are now changed to daily regimen. Ethambutol is now being added in the continuation phase. Fixed dose combinations we are giving now. All TB patients must be notified, even in the private sector. Universal DSP, that every patient who has been confirmed with tuberculosis must be offered CBNAT. Chest radiograph and sputum AFB are the earliest and easiest and cost-effective methods to identify TB patients and those with chronic cough. Early identification reduces both the bacterial load, the complications, and even the incidence of drug resistance. Thank you.
I have a question for you. Has TB really reduced in India? In spite of all these management techniques, the incidence of tuberculosis is still on the high. Do you think by 2025 we will eradicate tuberculosis? Not
for government wants to eradicate, they are implementing programs for that, but still we are having cases of tuberculosis.
And you didn't mention about prophylaxis for tuberculosis. Prophylaxis for people who are with sputum positive.
Actually, this is from Chennai Corporation. What they are saying is should give 6 months of isoniazid. They are indicating for household contacts of tuberculosis patients. But what they are saying is, even if you give a single drug, they are NIRT center for them to check, but they are assessed and they are saying there is no high incidence of resistance. But a lot of people have pulmonologists, we are still skeptical of giving a single drug. Because if the patient is found to be infected and we are going to give isoniazid as a single drug, it might turn out to be resistant. But as far as the guidelines are concerned, what they are advocating is all the household contacts of tuberculosis patients must be screened via X-ray and a sputum examination. Say if the father is turned out to be a sputum positive patient, the mother and the children, they should be offered X-ray and sputum examination. If it's found to be negative, they should be started 6 months of isoniazid. That is was Chennai Corporation's recommendation for TB prophylaxis for 6 months duration from March of this year. 6 months of isoniazid acid, around 300 mg per day. Excellent.
Can I have a word?
Please.
Sir, actually, sputum acid is a wonderful topic. We can just go on making it interesting for 1 hour. And with the auscultation, we can make it for more than 2.5 hours and beat any in the masala cinema. And the mark sputum negative can never happen out of confusion between saliva and the sputum. Because saliva is mucus. Sputum is mucoid or purulent, and we have many varieties under them. And even patient himself can easily bring out the sputum, and sputum never get mixed with saliva. If it is getting mixed with saliva, it is not pathognomonic, it is opportunistic. So we need not treat. So without any other involvement, patient only with pulmonary tuberculosis, patient will be very sensitive. He can only give the sputum. And lab technician, just by inspection, we have treated just by inspection of the sputum. We have achieved results. Another sputum negative, false negative, out because of confusion between mucus and saliva and the sputum should never be accepted, should never be acknowledged.
Patient education from our end, that's what.
You need to educate. If it is that, you have to accept and say no. Patient to fault. Patient only with pulmonary tuberculosis, without any other involvement, neurological or any other tuberculosis, he will be very sensitive. He can only bring out the sputum if it is pulmonary tuberculosis.
Yes, ma'am.
And the patient fault is there.
Accepted, ma'am. But the thing is, we are giving sputum for AFP also, but for bacterial and fungal culture, other cultures also. Better to educate upfront from our end to give proper sputum so that diagnosis becomes easy.
Patient should be very sensitive.
So how many cases of INH euphoria you can come across in your clinical practice, and or how many patients you have stopped INH because of psychiatric
So INH, one is psychiatric, or other part of the neuro.
How many patients you come across in your practice?
Neuropathy is anywhere between 10 to 20%, but it resolves usually with pyridoxine supplementation. If it still doesn't with high dose pyridoxine, then we can plan, but mostly it's but psychosis is very rare. I've seen 1 or 2 cases.
You stop to INH and go for other tests, and after resolving this.
We usually get a psychiatrist's opinion. If they give some antipsychotics and still we then see with the antipsychotics and if it's still not going, then we stop.
Yes, sir. And how long, sir? After the symptoms resolve, you restart again?
1 week we assess maximum. So still not going with we get a psychiatric opinion. What they say we usually follow.
INH related psychiatric is reversible now. So once you stop the drug, you get a psychiatric opinion for that.
So
stop the
1 or 2 rare cases we have seen still persisting beyond that. But coexisting psychiatric disease still there.
When we put them on ATT, we always add pyridoxine as a supplement. So to overcome it. So I don't find the INH.
I'm seeing very rare. 1 or 2 cases only total. So let's say 20 cases per day, 1 or 2 in the total 5 years. Very rare.
But in our case, they give Benadryl along with that.
Benadryl we always add on.
But guidance is for only for pregnant or those with alcoholics and
It's
pregnant.
not routinely given by the
Not routine, but by the guidance, but we usually give it. But actually, for these patients, they advise a high dose Benadryl, even 100 mg.
Okay, 80 to 100 you can give.
100, 200 also.
So you spoke about monoresistance, right, sir? You specified about INH monoresistance. What about rifampicin monoresistance?
We still treat it as MDS.
Still treated as MD. But do you straight away go ahead giving the drugs, or do you wait for the second line LTA as well?
Second line MDR. For it comes under MDR, then what we'll do is, if you're saying rifampicin alone is resistant, right? So what we'll do is, rifampicin resistance, we'll see, we have said 2 regimens, right? One is shorter and another is longer. If you see shorter contains isoniazid. So shorter contains isoniazid acid in the intensive phase. So for if rifampicin alone is resistant, we can go ahead with this regimen. Then for both MDR, isoniazid and rifampicin both are resistant. For isoniazid, we need to check whether there are two genes. One is INHA and another is CAT gene. If either one is resistant, then we can also go with this regimen. If both are resistant, then we cannot give this regimen. For isoniazid, either INHA or CAT gene, either one is resistant, then we can give this regimen. For isoniazid, both the mutation points are resistant, then we have to go for all. We can't give this.
Rifampicin has to be given in empty stomach. We used to study that.
Yes.
Still, it's given in empty stomach.
So now we have given FTC, so all the tablets are given after.
You said it's a notifiable disease, but still the drugs are available in the private pharmacy. How can it be notified? Because every GP will write a drug.
But single drugs are rifampicin previously used to be
still available. Anti-TB drugs are available in every pharmacy.
That is because certain people, like say with liver disease or renal disease, we need to modify ATP in special conditions. For them to get the drugs, they are giving us still listed, but they are restricting from the long point of view. They are restricting the availability of individual drugs. But certain subset of patients with say liver disease or renal disease, where we need to modify ATP, in those with skin reactions also. They will be intolerant to any allergic to any one drug, wherein we will test each one of the drugs. So in those cases, we will be needing the individual drugs. So for that, they are still allowing it in the private.
Are there any questions?